Welcome friends, I am Dr. Manish Kulkarni, practicing pediatrician, Aurangabad, Maharashtra. We will be covering up the commonest vaccine which is used in our day-to-day practice, that is DPT. Though it is the most commonly used vaccine for decades together, there are lots of confusion and doubts surrounding this vaccine. Here I will try to simplify and clear most of your doubts. As you all know, this vaccine prevents against the three deadly diseases of the childhood, three major killers, that is diphtheria, pertussis and tetanus. Diphtheria, though the incidence is reduced, it still continues to be a threat to children under age of 5 years. In this graphical representation, you can see that the incidence of diphtheria has reduced dramatically after the introduction of DPT vaccination. And as the coverage has reached to 80 to 90% with the 3 doses of DPT, by 2016 the incidence has reduced down, but still it continues to be there. And you can see that India contributes to about 78% of the diphtheria cases worldwide, and the current statistics shows that the diphtheria is re-emerging in India. Next is pertussis. This is the classical features of pertussis, the whooping cough. It still prevails and is fairly underdiagnosed. The incidence is 20 to 40 million cases annually, with 2 to 4 lakh deaths are occurring. Reliable data from India is lacking, and despite the availability of the DPT vaccine for decades, the disease still continues. Here I just want to highlight is that irrespective of the immunization status, the pertussis can occur because neither the vaccination nor the natural infection confers you a long-lasting good immunity. So any child, even if he is immunized, vaccinated with prolonged cough, you can suspect pertussis in him. Tetanus, we all know it's Dhanurvata. It's an excellent example of vaccine preventable disease. And tetanus, because its ubiquitous nature, the spores are present everywhere, it can only be eliminated but not eradicated. And what we are more worried about, and luckily we are not seeing the cases of neonatal tetanus now. Neonatal tetanus is a fatal condition which affects the newborns less than 4 weeks of age due to some unhygienic practices and some social habits that applying cow dung to the umbilical cord, and in most common in the countries where the access to the basic health services is absent and the hygienic conditions are poor. These are the classical features. There is opisthotonus of neonatal tetanus, rhizus sardonicus. Now these are the various vaccines which contains diphtheria, tetanus and pertussis. There is a wholesale pertussis vaccine, acellular pertussis vaccine, DT, dual antigen, TD, Tdap, TT, and in various combinations with HIB, hepatitis B, IPV. Now what are all those acronyms denote? WP, there is a wholesale killed vaccine. AP, there are no cells but there are constituent components which are pertussis toxin, which is the most important and should be present in all the acellular pertussis vaccine. There is filamentous hemagglutinin, pertactin, fimbrial agglutinin 1, 2 and 3, and lowercase AP, it contains a lower dose of pertussis components. So these are the DPT vaccines which we are commonly using. There is a wholesale DPT vaccine. It's used for children less than 7 years of age. It contains diphtheria, which is 25 Log+ unit, pertussis, that is 16 OU units, tetanus 5 Log+ units. There is a DT vaccine which contains only diphtheria and tetanus. It's used for children less than 7 years of age. This is acellular pertussis vaccine, DTAP. It's used for children less than 7 years of age. It contains diphtheria, 25 Log+ unit, tetanus 5 and pertussis, not the wholesale but the different components. There is TD-Vac. Now this vaccine is a dual vaccine which is used for children more than 7 years of age. It contains lower dose of diphtheria, that is 5 Log+ units, and tetanus, which is 5 Log+ units. Tdap vaccine, it's used for children more than 7 years of age. Again it contains low dose of your diphtheria and acellular pertussis. Tetanus component remains the same, that is 5 Log+ units. And then there is a TT vaccine which contains only tetanus toxoid, which is used for children more than 10 years of age, and it contains tetanus toxoid, which is 5 Log+ units. And I think we are confused more. Again, which DPT vaccine should I use? So let me clarify it a little bit. In the vaccine which has got uppercase D and P, that is capital D and P, are used for children less than 7 years of age, and those with the lowercase d and p, that is lower dose of diphtheria and pertussis components, are used for children more than 7 years of age. Why this is so? That is because the reactogenicity to this vaccine after the 7 years of age with the regular dose is more. So we need to go the lower dose for the children more than 7 years of age. Only wholesale pertussis vaccine. Then there is a wholesale DPT with hepatitis B. Then there is a DPT wholesale hepatitis B and HIV. Then there is a wholesale DPT with HIV. There is a DT vaccine. For children less than 7 years, now we have got the hexavalent vaccines which are latest in the market, which are wholesale DPT, hepatitis B, HIV, IPV. Then we have got the acellular one with the acellular pertussis vaccine, hepatitis B, HIV, HPV, the acellular pertussis with HIV and IPV without hepatitis B. Now for children more than 7 years, as we know, we need to have the lower dose of diphtheria and pertussis. So we have got Tdap and Tdvac. Now just few salient features about the DPT vaccine, the wholesale. The maximum age of vaccination is 7 years, because we know that after 7 years we can't give this vaccine because the reactogenicity is more. The minimum age at which you can start the vaccination is 6 weeks. The minimum age for first booster is 12 months, provided there is a gap of 6 months have passed after the third dose. The minimum age for the second booster is 4 years. Maximum in any circumstances you can give 6 doses. The minimum interval between the third and the fourth dose, as well as the fourth and the fifth dose, is 6 months. Now adverse effects are mainly because of the pertussis component. The most common are the fever, local reaction, there is pain, induration, redness and tenderness, which occurs 1 in 4 cases, so this is very common. There might be fussiness, reduced appetite, it might persist for 10 days. Now little uncommon side effects are inconsolable crying for more than 3 hours, febrile seizures, or even the seizures without fever are common. Hypotonic, hyporesponsive, shock-like episodes. Now there are certain contraindications and precautions while giving this DPT vaccine wholesale. Obvious contraindications are hypersensitivity or anaphylactic reaction to the previous dose and encephalopathy occurring within 7 days after the vaccination. And the precautions are any severe acute illness, progressive neurological illness, unexplained fever of more than 105 within 48 hours, hypotonic, hyporesponsive episode, shock-like state within 48 hours, persistent inconsolable crying within 48 hours, seizures with or without fever within 3 days, history of Guillain-Barré syndrome within 6 weeks of any TT containing vaccine, and Arthur's type of reaction to the previous TT or DT vaccine. So always remember that diphtheria immunization doesn't completely eliminate the carriage state. So the carriage percentage remains the same, so the organism might remain in the nasopharynx and the skin. Both diphtheria and tetanus, even if there is a natural infection, the patient needs to be vaccinated because it doesn't confer complete immunity. Interchanging of the brands is avoided. However, if the previous brand is not known or if it is not available, you can do so. If the first dose is given as an acellular pertussis vaccine, you can go ahead and give the second dose as a wholesale DPT. Now this is national schedule of the wholesale pertussis vaccine DPT. In the national immunization schedule, we give 3 primary doses, 6 weeks, 10 weeks and 14 weeks. 2 booster doses of DPT, they are given as 16 to 24 months and 4 to 5 years. And 2 boosters of TT at 10 years and 16 years. Dose, site and route of administration, we give it 0.5 ml intramuscularly. It's given anterolateral aspect of the thigh. The IAP recommendation of the wholesale schedule is the same as the national immunization schedule up to the age of 5 years. And IAP recommends that 1 booster dose of Tdap or Td should be given at 10 years to 12 years. And then TD boosters every 10 years. It is stored at 2 to 8 degrees centigrade and it's very freeze sensitive. Coming to EZ6 vaccine, this is a fully liquid hexavalent vaccine which contains the wholesale DPT. It contains HIV, hepatitis B and inactivated Salk poliovirus 1-2-3 vaccine. Currently, this is the only vaccine with the wholesale pertussis vaccine along with the injectable polio vaccine. The primary vaccination schedule is the same, 6, 10 and 14 weeks, and the adverse effects, the precautions, the contraindications are same as the wholesale pertussis vaccine. Currently, cost is the only barrier for this vaccine, and the advantage is definitely, as we have said, that the injectable polio vaccine is available along with the wholesale pertussis vaccine, and lesser number of pricks are given. Now coming to the acellular pertussis vaccine. After the introduction of the wholesale pertussis vaccine, the incidence of diphtheria, pertussis and tetanus diseases decreased dramatically worldwide, and it was reduced to such an extent that in the developed countries the people were not accepting the vaccine because of its reactogenicity, and therefore with the fear of this poor acceptance of the vaccine, the wholesale pertussis vaccine was stopped being used in the developed countries and they shifted to the acellular pertussis vaccine. So in acellular pertussis vaccine, there is no wholesale of pertussis, but there are certain immunogenic proteins or the components, and these are this pertussis toxin, which is very important and need to be present in each and every acellular pertussis vaccine. There is filamentous hemagglutinins, pertactin, fimbrial agglutinins 1, 2 and 3. So what are the IAPA recommendations for using the acellular pertussis vaccines? So only if there is a history of severe reactions with the wholesale pertussis vaccine, or it may be preferred in the cases where there is severe neurological disorders. It's not to be given beyond 7 years of age, and only if the parents demand it, you have to have 1:1 talk explaining to them this is gentle and not exactly painless, which is a fully liquid acellular hexavalent vaccine. It contains diphtheria toxoid, tetanus toxoid, acellular pertussis components 2 in number, HIV, hepatitis B and all 3 IPV antigens. So it's a combination vaccine, so number of pricks are reduced. Seroconversion against all the 6 components after 3 primary doses is satisfactory with a good safety profile, which is recently being launched in Indian market. It's a freeze-dried vaccine, needs to be reconstituted before giving injection, and it contains 3 components of acellular pertussis. Now the choice of the vaccine, whether I should be using the wholesale vaccine versus the acellular pertussis vaccine. There are certain concerns about these vaccines. The first and the foremost is the duration of protection. It has been seen that the protective immunity starts waning both after the wholesale as well as the acellular pertussis vaccine, but it has been seen that the waning of the immunity with the acellular vaccine is rapid compared to the wholesale pertussis. So unless regular boosters are being used, the acellular pertussis vaccine immunity wanes off. Then the preference of a particular acellular vaccine product. There is general no consensus regarding the antigenic composition of the ideal acellular pertussis vaccine. The exact contribution of the different antigens is not known according to protection. It's still not clear. And then to confuse it further, we got the pertussis outbreaks. In the countries, most of the countries which were using the acellular pertussis vaccines for decades in their national immunization programs had these outbreaks. We had the outbreak in USA in 2010, Washington in 2012, UK, New Zealand and Australia. So the reasons were, apart from the waning immunity of the acellular pertussis vaccine, which was very rapid, the another things, reasons which were given were, first, the increased awareness of the people regarding the disease. More specific tests were being available, mostly the PCR test. Then the coverage of the vaccination, the percentage has reduced because the disease incidence had reduced. There were certain ethnic groups in which there was a primary vaccine failure, and in a few cases they said that it could be because of the mutation of the Bordetella pertussis organism per se. And so it cannot be entirely blamed to the acellular pertussis vaccine. And then to confuse us further, we got an outbreak in Khairpur, Sindh province, Pakistan in 2012. And this is a country which has been using, like India, the wholesale pertussis vaccine since 1980. So where we stand. So what are the IAP recommendations? IAP recommendations are to use the wholesale pertussis vaccine in the primary series. If you are using the acellular vaccine, if they are indicated, it can be given but need to be followed up with the timely boosters. And acellular vaccine ideally should contain 3 or more components to be very effective. However, we have seen that the success story of wholesale pertussis vaccine, we have been using this vaccine since the inception of expanded program of immunization in 1978. So we have seen that the disease have reduced dramatically, and also regarding the safety profile, we have been using these vaccines for many decades and still there is no reporting of the higher incidences of severe side effects after this vaccination. And the developed countries had shifted to acellular pertussis vaccines because the vaccines were reactogenic, and we still don't have any such issues regarding the vaccine acceptance because of the reactogenicity. So countries like India, where there is a poor vaccination coverage both for the primary as well as the boosters, it cannot be recommended for the mass scale use. Moving to the next vaccine, Tdap, its recommended age is 10 to 64 years. As of now, only a single dose is recommended. The gap between TT and DT vaccine should be at least 5 years, but in certain situations where there is an outbreak or epidemic, it can be reduced to 2 years or it can be ignored. This is not for the second booster and it should not be used below 7 years of age. Adverse effects are fever, mild local reactions. Contraindications are anaphylaxis to the previous dose and encephalopathy within 7 days. There are certain precautions like moderate to severe acute illness, history of Arthur's reaction following TT, DT or meningococcal conjugate vaccine, Guillain-Barré syndrome within 6 weeks, and progressive unstable neurological disorder. What is the rationale of introducing Tdap at 10 years of age? We have seen that the immunity after both wholesale as well as acellular pertussis against all the 3 diseases, it starts waning, and by the age of 10 years, most of the cases the antibody titers are very low. And because of the primary vaccination in the childhood, we have seen that the natural boosting because of this organism and infection in adolescent and adults has become very less. So these are the susceptible population. Now we have seen that there are 2 scenarios. Initially we were in the first zone when there was no vaccination, so there was a high incidence in the first few years of age. So there was frequent natural boosting, so we could confer immunity to the adolescent and adults, and disease continued to prevail in the young children. However, there was very high mortality and morbidity. So we can't remain in this scenario, so we have to move to the other scenario where there was a high coverage rate, which is happening in the developing countries like India. So with the increasing vaccination coverage in the pediatric age group, the disease incidence and the natural infection is getting reduced. So waning of the immunity occurs in adolescent and adults. So disease is relatively common again in the infants less than 6 months and also in the adolescent and adults. So this is the population around 10 years of age with the waning immunity. So we need to target them. And also in the national immunization schedule at the 10 years of age, we had a vaccine for these children, that is TT vaccine. So it was very easy to substitute the Tdap with the TT vaccine. How many doses are recommended? At present, only a single dose is recommended. If by mistake a Tdap vaccine is given instead of DTaP, what should I do? See, we know that any dose which is less than optimal is not counted. So in Tdap, there is a low dose of pertussis and diphtheria. So it is not optimal. So we don't count that dose and we give the regular, the capital acellular pertussis full dose. There is no gap is required in between because these are killed vaccines. So as soon as the mistake is recognized and the patient is ready, you can vaccinate. Now tetanus vaccine. Tetanus vaccine is a single tetanus toxoid vaccine. Its clinical efficacy is 100% after a primary series. It is quite stable to heat, but it is freeze sensitive. It needs to be stored at 2 to 8 degrees centigrade in a refrigerator. It is given 0.5 ml intramuscular in the deltoid region, and you use the AD syringe and 24 gauge needle for it. The adverse effect, this pain, induration, swelling, redness and fever, and there is certain Arthur's type of reaction which is antigen antibody mediated reaction, local inflammation and vasculitis, which is characterized by severe pain, swelling, induration, edema, hemorrhage and occasionally by necrosis. And these symptoms and signs usually occur 4 to 12 hours after the vaccination, and therefore the repeated TT vaccines need to be avoided. Now this is the most important is the prevention of the neonatal tetanus. So the promotion of the safe hospital deliveries, educate the pregnant woman, and the immunization of the pregnant woman with tetanus toxoid. So national immunization schedule is you give 2 doses of TT 1 month interval to unimmunized mothers. First dose as early as possible with the first contact with the healthcare workers, and the second dose after a month of the first dose. The schedule should be completed at least 3 weeks prior to the delivery to be effective, and you require only one dose if the mother is immunized within 3 years of the previous delivery. But IAP recommends is if the mother has received 3 primary doses, either wholesale or acellular, and 2 boosters in the childhood, she requires only 1 dose is needed during first pregnancy, and in such movement there is no need to give additional doses in subsequent pregnancies. Now, tetanus toxoids in wound management, it depends on the how much tetanus vaccines you have taken, how many doses, and the time which is elapsed since the vaccination. So, if the child has taken 3 or more doses and the years which are less than 5 years since the last dose, all the types of wounds you don't require either tetanus toxoid booster, or you don't require tetanus immunoglobulin. If 5 to 10 years since the last dose, clean minor wounds don't require to do anything. All the other wounds you require only the tetanus booster, no need to give tetanus TIG. If more than 10 years have passed since the last dose, all the wounds you need to give tetanus toxoid, but no TIG still. Only if the doses are less than 3 or uncertain, there is no history. All the clean minor wounds you still need to give 1 tetanus toxoid, but no tetanus immunoglobulin is required, and all the other wounds you need to give TIG along with the tetanus toxoid. So, what is the catch of vaccination? So, whenever there is a missed vaccination or there is a gap in the series, you need to just complete the series, no need to restart it. So, for the children below 7 years of age, either with the wholesale pertussis or acellular pertussis, the dose is 0, 1, 2 and 6 months after the last dose. The second booster is not required if the first dose is given beyond 4 years of age. For the children above 7 years of age, Tdap as a 0 dose, TD at 1 month and 6 months, which is followed by TD every 10 years of age. 11 to 18 years, you give a Tdap dose as a single dose, and later TD every 10 years thereafter. If the child shows reactions like high fever, convulsion, inconsolable crying, can we give the wholesale DPT in the subsequent doses? Is it preferable to switch to acellular pertussis vaccine? As we have seen that all these side effects, systemic side effects of high grade fever and convulsions with the wholesale pertussis vaccines are very common with the first dose. In fact, the systemic side effects reduce and the local reactions increase with the subsequent dosing. So, if you can counsel the parents that it is safe to give the wholesale pertussis vaccine for the subsequent doses, you go ahead and give the wholesale vaccine. It is not a contraindication for giving the wholesale vaccines in the subsequent doses. However, if the parents insist, then with the 1:1 talk along with telling them that you can reduce the side effects only in the 2/3% of the cases, in 1/3 cases you can still get the reactions. You can go ahead and give wholesale acellular pertussis vaccine. 1-year-old child who is unvaccinated, just recovered from whooping cough, the child needs to be vaccinated, whether we should use DPT or DT. As we have seen that the natural infection does not confer a lifelong immunity and a good protective immunity. So, this child needs to be vaccinated and should be vaccinated with the DPT vaccine. Thank you.